Helen Chen is a professor in the School of Public Health Sciences. Her research and teaching interests are in health system interoperability and health informatics. Helen recently has focused her efforts in developing AI algorithms to generate synthetic health datasets and data governance around such datasets. Thank you, Helen.
Thank you. Yeah, so that's how you get a professor talking about their research, and it's very hard to stop. So I brought my own stopper. Okay, they will beep. Okay. Yeah, so thanks, and my colleagues, and it's very, they are much at a higher level. They talk about the differential privacy. Gotham, we need to have a private talk. Because my previous master student, Shubankar, I think he's a PhD now, we talk about the differential privacy in the federated learning. Yeah, so Professor Gong talked about this very high-end futuristic, but today I'm going to talk about another concept. But Gotham already killed me. He said it cannot be in synthetic data, cannot be completely private. Okay, but let's actually take a look of this beast of sharing the data, holding the data, use the data, building trust from slightly different angle, okay? So let's climb the mountain from a different path. And I cannot say this is the only path, but it's one of the paths, may solve some of the problem that we are facing. So I'm talking about the synthetic health data. I think the synthetic generative, the word does not really need another introduction. And then because ChatGPT took the society by storm. So I just actually finished the 2-day training of redesigning a curriculum of assessment tool in the era of ChatGPT, right? So that's kind of very, very disruptive technology arrived here. But I come to this concept that 1.5 years ago, and by introducing, actually I met Dr. Alan Foster. He is the VP for innovation in your very own Ottawa hospital. And many work I talked today and the concept we talked today actually started that first hello with Alan Rector Foster. And when he was saying that Ottawa hospital, how they democratize their data, that's one way I actually like that word very much. And the second is that he actually mentioning of the synthetic data, how quickly they actually can get the data, train their physicians, looking at their data, and potentially can share the data with University of Waterloo researcher. I immediately jump on, I raise my hand. So that beautiful friendship started 1.5 years ago when I met Alan. Okay, so the concept is synthetic data is we're saying data is a field. I don't need to talk about it. And I also don't want to talk about the challenges because today from everybody's talking about challenges with very well arranged challenges. For the people, colleagues working in Kai-Hai and working in StatsCan, you are that blue sky or those vast sky there. You have lots of data. You have a sea of data. But we looking at you from far. And the Waterloo researchers and the AI institutes and our PhDs, master students, they are dying. Say, how about if I have some data? How about if I have some data? We are looking at those little spots from here and there, okay? So that's how we feel that your data look to us. Sometimes it is isolated and it's quite hard to get. So that's our challenges we talk about. But we all talk about how the scandals and the things we live with that, and the worry about the leaking of the patient data, trust that violate that trust of people actually put their data in your good hand. You want to trust it. But let's take a look of what the data is used, because we know sometimes that the data needs to be even down to the very single personal records, right? That's why you trust your doctors, looking at a very individual level. But many times, they actually don't need that very individual level, but they need to actually very realistic data. So if you look at the data here, and there are a bunch of numbers, Okay, and but what we normally want to see, lots of them wants to see, is that what this data tell us a picture is actually this is Ottawa Hospital. We were there 2-3 weeks ago, and so we need to know what the picture look like, but we actually don't need to know what that very single line, the first line, the second line, this is a picture, so that's RGB and the numbers, right? So what if you don't want me show you every single line, but I still want to know there's a picture there very realistically, and I actually generating a synthetic data, okay? And this data have absolutely no one-to-one relationship. It's not de-anonymized data. It's actually somehow magically we generate. We're going to get to the magic, probably another talk, but somehow you can actually generating that data, and they will show this picture. And this picture, whoever visited that hospital, you will know, you say, yeah, that's Ottawa Hospital. But if you actually going back to each individual line, I'm not talking about adding a little bit of noise or adding about, there's no 101 mapping back, trace back to it. Okay, and then you can see that it's the original picture, and this is the generated picture, right? We understand that, but we have no single line of coming back. So if you look at what is the synthetic data, the synthetic data have many ways of generating synthetic data. Myself, last year, 2 years ago, I was teaching for public health, and I have no other data rather than say go to the mimic data sets, which is actually, it's an ICU, and from hospitals in the US. We're generating hundreds and hundreds of papers and AI models of mimic data sets. But that's not really reflecting Canadian systems to a large extent, right? So the synthetic data is you generated based on the real data, but you generated through representing have a similar characteristics. That similar characteristics, it's up for you to define what you mean by characteristics. So that's where we're coming back to say what you want to be used for, what you want to use for it. Do you want to just looking at population statistics? Do you actually want to have a longitudinal data, very realistic patient record testing your robots, testing your software? Right? And or do you actually want to find that very precise patient and wants to find the personalized care plan for that patients? So there's a many use of the data you want. And some of them synthetic data cannot do for you, but some of them they may, such as testing your software, such as training your AI model for the first round. And you can further train them when you have a real data. When you really have the very specific data, Ottawa Hospital, Grand River Hospital, or UHN data, you can go on further training those data. But you can let the Waterloo researchers and the hundreds of PhDs, master students to play with that data now. And then you can take those models and go continue to train. So that's the whole idea of it. And then, so if you look at these charts, okay, so the StatsCan and the CaiHi, you hold lots of such data of the population. And what you need to do is that you said, I want to see my population a diabetic kind of characteristics of a diabetic population. But you actually don't need the individual patients. But you need those patients very realistically understand the cohort. So that is the idea of you see those people in the synthetic data sets, and they are nothing looking like any individual on your real sets. But when you look at cohort statistics, you build a model to predict, for example, your mortality of the COVID, right, patients. They can be very, very close for that purpose, okay? So if you look at it, there's a generation, how to generate it. So I'm not going to go into detail or not show you any of the mathematical models. But basically to saying that there's a new way of generating the synthetic data is that I learn, if you're 100 patient, give me 100 patient with like a 300, I should say, give me 3,000 patients with 100 variables, you have it there. I learn I build a deep neural network, and I generate each one of them, I generate a new patient, and then that I will go against to compare. Just like Gotham pointed out how you're actually doing the membership inferencing and attacking, etc. I will iteratively, diligently to run to make sure that patient I generated, there's no way you can inferencing. Oh, I should say no way. My lawyer colleague told me, never say no, never. He said very, very low chance you actually can say that person is in, you generated that generated member, and it's actually the real member in that real data sets. Okay, very, very low. Okay, whatever Gotham saying, how many degrees of low risks, and hopefully we can reach that level. So that is actually the new way of generating the synthetic data. Okay, you based on the real data, the knowledge, and they generate another population, and you can do things with it. Okay, what actually you can do? So this is actually Professor Ali Elman, I think the Kai-Hai colleagues also working with him. He's an expert and in the Ottawa Hospital, and he actually was working on this field quite a bit. And he published the paper and on to saying that when he built the model and also looking at the association, what is impact factors actually leads to the COVID mortality. And he concluded that, first of all, he concluded the model is quite usable and it was very, very close accuracy-wise. And the association factors is also very, very usable. And also he is by himself, he's actually a privacy expert, and he used his methods and actually rigorously measure the disclosure, the risks of actually membership risks. And he concluded that he published to say it's actually very, very low. So as a result, what the implication? Implication is that we truly can now practice the open data and open science. We always driving, especially in the AI field, if you want to increase the trust, what do? You need to actually hold accountable, reproducible, and transparent, right? So those few keywords, but if you hold the data, you cannot have my data, then how I'm going to trust your model? Because the data is your model is the data. So that is how you can actually facilitate some level of the open data and the open science. I'm a radical here. I can see people start thinking, but I'm a radical here. Just imagine if we can reach that algorithm is good enough, okay? So that is a vision we are moving forward. And I'm not saying Kai-Hai would just suddenly become the open science, open data organization. Everybody can go access your data, no. But there are certain things we may be able to allow people to use it much faster than the current practice. Okay, so what synthetics is used for and what they are not really can completely. So from our point of view, software testing and the system validation, right? And actually building your AI model, the first layer at least. And if you want to read any of the cohort characteristics, you can actually do that fairly fast. Okay, so that's what we are doing right now. I actually don't want to steal the thunder of my colleagues in Ottawa Hospital because they have a massive events next Tuesday. I encourage you to actually to register and listen what they are doing. So that is what we do, is to saying that if we have some problem, they have some problem interesting, they want Waterloo researchers want to actually help them, and we have some investigation we want to do on their data, that we can first engage in the synthetic data level. And then we gradually drill down, right? So those kind of collaboration becomes a very different stage. We can collaborate, we can access the data, okay? So there's a multi-layer privacy solutions. I'm not saying that you now don't need to hold your data very, very privately, very securely. Yes, you can, you have to. for that. But there's a multi-layers that you need. And many times we accumulate so much data in the hospital. And so in my own, I teach health informatics program and master PhD. We have master of health informatics program and shamelessly advertise a little bit. So those doctors and nurses and the people working in the hospital, they are the data generator and they make the difference. If they can have the data very fast at their fingertip, and they can change, they can learn, and facilitate learning health systems. They can learn, and in turn, when they use the data, they will drive the data quality much, much higher. If the data that's submitted to CAI, they never actually see to use it, it's a coder actually coding those data submitted to CAI. That's a little bit different from the doctors and nurses. They actually say, oh yeah, well, why we miss some data and the arrival data is probably not what we should code. If that's the case coming, then data quality will be so much higher, right? And then they have so many people in the middle layer, they can do internal research as well. And for us, for our third-party industry, Waterloo AI researchers, they can have the data to train their model to learn and to actually facilitate the close collaboration very, very fast. So that is a synthetic data layer I'm talking about. So it's a multi-layer of accessing the data. And for that, we were hoping to change the paradigm to collaborate. So we already have the roundtable end of March, which is very good, actually, roundtable at our hospital. And we actually recently, yesterday, was getting another grant and from OPC and the Ontario Privacy Office to look at the governance structure valuation of the synthetic data. And hopefully we can really facilitate a good governance structure, good actually the way of measuring the quality of the synthetic data, governing of the synthetic data, and the value of the synthetic data, and that will, the whole country will become a very different game, really, and with our AI industry here. But without data, there's no industry. Without a health data, realistic, good quality health data, there's no health data science, really, right? So who is actually using it? This is a courtesy of a vendor. We happen to, actually, Ottawa Hospital happened to use it. But it's actually, there's many different hospitals are using this scheme to collaborate. And MD Chrome is Israeli company. So they actually was installing in the Sheba Medical Center and the VA in the US and the Intermountain, etc. Now Ottawa Hospital is using their platform. The whole idea is actually be able to very fast to get the data from internally, all their physicians can get their data to do the kind of WYSIWYG ad hoc query very quickly. And then also they can generate in the synthetic data off their EMR systems and allow somebody like us to use it very, very fast. So we are actually working with them to establish the data sharing agreement, REB approval, and all these processes being ironed out as we speak. Okay, and so that is another way of this way. I actually visited the Sheba Medical Center in February with Ottawa Hospital team. And what impressed me is that one of the doctors, and she was actually has a maternity leave, and she came out to discuss, to show us how she used the data and to very quickly and change her type of practice, because she see the data and she do analysis and she said, oh yeah, I want to change the drug prescription pattern. And she changed, they can actually quantify the better clinical outcome, quantify the cost savings. And it's very fast. So I like that way of democratize the data. If you actually don't let those doctors, nurses, and which has the very good knowledge and they can change their practice when they see the evidence in front of their eyes, if you don't allow those kind of people using the data, then our learning systems learn quite slowly, right? So that is one way. And another is that I attended a Lancet summit at the COVID strategy in data. And so they actually they have some case studies looking at how fast the data they actually using the synthetic data and to exchange create the digital twin and to actually look at the responses of the vaccine to identify what the people actually are at the risks immediately. And the doctors start calling those people personally to say, you have to come, you are in a high risk, you have to come to get the vaccination. So those kind of actually be able to acting upon very fast of the data insights. And that is attracted to me. I thought, oh, this is actually, we should have been working on these kind of things to improve the algorithm and to do that. So there's a UK also, I think it's equivalent to saying they collect the data for research purposes, like in the Kai-Hai. And you see, no, okay, so I have to stop. But there are started to have some opportunities now to actually start to collect the good quality of data, and then you can actually start releasing some level of synthetic data and for the other purposes. So the idea is that we are actually pushing forward for pan-Canadian federated synthetic health data network. That's a key, okay? And I claim that all my graphs are generated or synthetic graph, okay? So that is what we're seeing for each. Imagine a world we actually can have that engine generating on the public clinic, on the hospital, and the synthetic data very closely resemble the characteristics. And if there is things needs to be compared quickly, if there is a model generated in Ottawa Hospital, can very quickly goes to get validated and used in Grand River Hospital or in natural Nunavut, then how that would actually fundamentally change the way we practice, we develop the AI tools, we develop the insights, right? And so that is what we want to actually facilitate and try to do that. The first, that's my last one, is to build a trust. How to build a trust? You actually need to make it explicit. What is the risk of re-identification? What is the quality? How you actually say which algorithm you use, and how I'm going to trust your synthetic data, how close that to your real data, in what form, okay? And so that is where we want to establish. So the work has begun, and I actually was very excited with this type of work. And then Tuesday, and I'm very happy to see that Ottawa Hospital, what the cases they are. They are not talking about, since they launched this, they call the Adam Center, and it's not, they're not talking about 2 projects, 3 projects. They're talking about 30 projects in a couple of months. The physicians and doctors and say, I have these problems. I want to investigate this problem. And they started. And they got the data right there. And so that's the end of my conversation, and also the Kai-Hai people here, and Jeff and now here, and we are also start talking, and hopefully we can work together on this subject.